Yeah, dear Hedi, thank you very much for this kind introduction. I hope you can hear me clearly and also see my slides clearly. I'm also very grateful to be able to present and give this little lecture on acupuncture and traumatization, which is one of my favorites, well, acupuncture in psychiatry topics. So let me just check where I can go further. Yes. So here are my conflicts of interest. Apart from being a lecturer in acupuncture, I'm also NADA trainer, and I received some honoraria from some pharmaceutical companies as well. In this presentation, I will give a quick summary about post-traumatic stress disorder and standard of care in trauma therapy. And then I clustered it with three different acupuncture approaches. One is strategies for early intervention, then symptom-focused interventions, and then exposition-based interventions. And I will close with a summary and discussion. This is a scheme about consequences of traumatization. I know it's in German, but it's, I think, easy to follow. So after a traumatic event, you can either have a kind of acute reaction or a kind of adjustment disorder, and eventually, hopefully, getting this integrated and compensated. But you can also have the full-blown picture of post-traumatic stress disorder, even more complex forms like personality changes. And they may have also comorbidity with depression, anxiety, somatization, or addiction. PTSD is quite common, and more than half of the general population will experience during their life some potential traumatizing events, yet not all of them, of course, develop PTSD. It's more common in women and less common in men, and the lifetime prevalence is about 5 to 6% in men and 10 to 12% in women. Lifetime risk increases according to the nature of the trauma. So it's most common after man-made traumas, and the highest risk is after rape, and then followed war, crimes, and abuse in early childhood. And of course, then at the moment we have this terrible war in the Ukraine, and we will get a lot of PTSD patients in the future from this war. It's less common after accidents or witnessing accidents or violence. Here's just an overview of the still current ICD-10 criteria. So criterion A is the exposure to a stressful event or situation of exceptionally threatening or catastrophic nature. And then the symptom criteria are B, a persistent remembering or reliving the stressor by either intrusive flashbacks or vivid memories or recurring dreams. Criterion C is actual or preferred avoidance of the circumstances resembling or associated with the stressor. And then finally, criterion D is either the inability to recall parts or the event at all, or persistent symptoms of hyperarousal, such as hypervigilance or difficulty in concentrating. There are also different types of traumata, and the prototype is the type 1 trauma after a single short-term event, which could be either accidental, like a work-related accident, or interpersonal trauma, like being a victim from a sexual assault or a physical attack. And more long-term or multiple events then may lead to type 2 traumatization or more complex forms after natural disasters with long-term consequences like earthquakes or floods, or years of sexual or emotional or physical violence or abuse during childhood, for example, or during war times. There's a vast literature now about consequences after adverse childhood experience, and these will increase a lot of psychiatric symptoms like higher risks for dissociations or hallucinations, impulsivity, suicidality, or development of personality disorders. But also somatic diseases have a higher risk to develop, like asthma, infections, or sleep disturbances. Once there is a traumatic event, there is a cascade of neurophysiological reactions. This is, of course, very, very brief, but of course, in the first place, our sense organs react to the stimulus, and then this comes to the thalamus, which assesses the relevance and filters the information, and the thalamus blinks, well, this is now highly relevant. Then the amygdala pops in and judges the hazard and risk, and also is responsible for regulating emotion, and it judges, well, this is highly dangerous. And then comes a hormone reaction with releasing of stress hormones like noradrenaline or cortisol, and also inflammatory substances. And the consequences from these neurophysiological reactions is a fear conditioning of stimuli related to the initial event upon triggers in the future. The experience is not implemented in the explicit memory as part of a chronological row of events, which can be expressed verbally later on, yet the traumatic event remains within the implicit memory, and those memories come further up as flooded negative emotions and physical reactions. And these memories remain pathogenic and fragmented. Standards of care in trauma therapy involve, also very, very briefly, you can do a psychological first aid, let's say after an accident or a natural catastrophe. And within the early few first days or weeks, you can do different forms of early interventions. And if one has the full-blown picture of PTSD, first line of treatment are certain forms of psychotherapy, like cognitive behavioral therapy or eye movement desensitization and reprocessing. And meta-analysis have shown the most effective forms have some kind of confrontation. Most trauma therapies are this model, a phase-oriented therapy, the basis formed of safety and stabilization techniques, and the central element is confrontation, and it is finished with integrating the traumatic event into the life. This central element of confrontation is usually done like it is sketched here. So usually the traumatic event is repeated in a safe environment with all senses, and upcoming thoughts and feelings are described, and through repetition, habituation is promoted and negative emotions can calm down. And the distorted traumatic memory newly arranges and dysfunctional cognitions are identified and modified. Here is some results from the meta-analysis. So trauma-focused techniques like trauma-focused CBT or EMDR have the highest efficacies compared to more unspecific forms of group therapy or even pharmacotherapy. So after this introduction, I will show you some strategies which have been applied for or after traumatizations. And I will start with approaches of early interventions. Here, quite often or usually the NADA protocol is applied. NADA from National Acupuncture Detoxification Association, which was first implemented in the 80s for patients with addiction, but is now really globally used for psychiatric patients. It implies these 5 points: sympathetic, Schönman, kidney, liver, and yang. It is usually done within a group setting, and you can use 5 points each ear or even less if somebody has very sensible ears. And it has a non-confrontational and non-verbal nature of approach. It also should include psychosocial support and some form of tea. Patients usually describe afterwards some form of relaxed alertness, and that the NADA has given them an impulse for inner processes, and it has strengthened their ability for processing information and emotions. Here just some pictures from the German Journal of Acupuncture, where different authors described NADA protocol in areas of natural disaster, for example, here in Kenya, or after an uproar in Kenya, or in natural disasters in Haiti. There are also examples in the Philippines. It can be easily done also for children. Sometimes then magnetic beads are used. And as you can see, NADA, because it's very easy to implement, has the ability to be applied for many, many patients in a very short period of time. There are other examples for applications of the NADA protocol in traumatized patients, like a treatment of traumatized refugees, which is done, for example, in Augsburg, or support for complex PTSD patients in an outpatient care unit in Dresden, or for traumatized children and adolescents, for example, at the University Hospital in Leipzig. Another form of an easy to implement approach is the battlefield acupuncture. It's another example of a 5-point selection acupuncture. Both share Shen-Men, but battlefield acupuncture then uses omega-2, 0.0, thalamus, and cingulate gyrus. It was first developed to treat military members really at the front, but is now more used for veterans and has an indication for pain states, and is kind of a reaction towards the opioid crisis in the US. So both NADA and battlefield acupuncture are easy to implement, yet the evidence for both of them through vigorous scientific approaches is limited. So I come to symptom-based approaches, and there is a larger scientific basis for these kind of approaches. I have brought a meta-analysis from 2017, which included 7 studies with over 700 participants. And the different studies applied acupuncture for 30 to 60 minutes, 2 to 4 times per week, and over a period of 3 to 12 weeks. And the authors measured PTSD symptoms, depressivity, sleep disturbances, and anxiety. Here you can see the different trials. And here you can see the acupoints. So some used body acupuncture, others used ear acupuncture. And the comparators were treatment as usual, or some form of pharmacotherapy like an SSRI, or even cognitive behavioral therapy. And the results show, yes, indeed, acupuncture was in favor at the end of treatment in this forest plot, and also after 1 to 6 month follow-up. And the last approach is exposition-based approaches, or exposition-based acupuncture. This is how we named the technique, initially developed by Jürgen Schottdorf from Friedberg near to Augsburg in Germany. And we both published it in the German Medical Journal for Acupuncture. And the general approach with this exposition-based acupuncture includes 4 steps of treatment. After getting known to the patient and knowing what has happened and knowing a little bit about the traumatic event, in the first step, we do some form of constitutional treatment, for example, using palpation-based acupuncture in the style of Kiko Matsumoto. And then the patient is asked to visualize the image. And step 2 and step 3, we named psychosomatic and psychologic. So the physiological and feelings coming up after imagination are then treated. And the last step we call emotional, as the predominant color of the image is treated in the last step. I go a little bit more into detail of the therapeutic approach. So after the constitutional treatment, you ask the patient to imagine the traumatic event, maybe not the worst part of it, but some part of it that can evoke a bodily or physiological reaction. And then you ask questions like, well, what kind of bodily experiences or feelings come up while you visualize this picture? And then these upcoming bodily sensations are treated with corresponding acupuncture points. I give you some examples here. For example, if the patient says, well, looking at this picture, I have some form of thoracic constriction, you may use pericardium 6. At the first place, we touch or press the point with our fingers. And if it's doing any effect, we insert a needle. We use very short and thin needles. Or another example, if the patient says, well, just my whole body is under tension, I, for example, will try to use liver 3 or large intestine 4. Or if a patient says, well, I have some feelings of anger, then maybe liver 2 or liver 3 are good points to use. Or if the patient says, well, now experience some form of sadness, then you may use some points from the lung channel. So usually after 3 to 4 or sometimes more rounds with this approach, we ask the patients, well, has the picture changed in any form? And usually the patients say, well, it now is a little bit more blurry or more far away or less intense or less colorful. And then we sometimes ask, is there any particular color? And if the patient says, well, it's kind of bluish or darkish, we may try points on the kidney channel. In the end, I try to treat the picture itself using points on the left or above the left dorsolateral prefrontal cortex using palpation and asking the patient whether this point is doing any good. And in the end, usually the picture completely vanishes after or underneath a kind of blurry vision, and it's not, patient is not able to getting back or visualize this picture again. Here's some results from a first case series, from a first one showing a nice reduction in depressive symptoms and trauma-related symptoms. And here results from a second prospective trial with nearly 60 patients. We also had a 3-month follow-up in this trial, and all trauma-related symptoms, but also depressive symptoms or pain really changed significantly after treatment and also after 3 months. And only a mean of 5 treatment sessions really was needed to treat these conditions. Here is some box plots for the change of depressive symptoms and the change of intrusions, nicely showing the reduction of symptoms. And here is our future perspectives. We are now doing the SNAP study. Jonas is also in the webinar, and we're trying to find out what is happening within the brain using EEG and also heart rate variability. Just in 2022, there's another form of memory-directed acupuncture published in Translational Psychiatry using acupuncture within a trauma therapy session, which also seems to be very promising. So to summarize, trauma-related disorders are highly relevant mental problems. Exposition is a central part of trauma therapy, and early interventions include NADA or battlefield acupuncture. You can also treat trauma-related symptoms using body acupuncture, or you can try to ameliorate symptoms using exposition-based methods of acupuncture. A lot of open questions. So which patient profit the most from which intervention, or how do acupuncture compare with standard of care? What are the underlying mechanisms, and so on. So I thank you for your audience, and thanks to Jürgen Schottdorf and my doctoral students, Alina, Paulina, and Jonas, my cooperation partners, the DECFA and NADA teams, and many, many more.